part, right? This is for the billers and coders, eventually what justifies the bill, right? Here, the physician goes through each one of his diagnoses, right?
Mm-hmm.
So ideally, each one of these headliners should be a CPT code or an ICD-10 code, right?
Mm-hmm.
That something can be mapped to, right?
Mm-hmm.
And then he has a whole narrative, and as a surgeon, there's no way I'm doing this, right? So chest pain, probably what I'll write is consult cardiology, right? Period, right? But he goes through and goes, oh, this is probably not related to chest pain. It might be related to reflux disease, right? And he goes through all these other symptoms, right? Shortness of breath, right? Dyspnea, shortness of breath, all mapped to the same idea. Completely interchangeable, right? But then you read into the fine details, and you're keying on things that are possible but not certain, right? So possible left ventricular dysfunction, suggestive of left ventricular, right? And the coders love this, right, or hate this because they don't know, should I put it on there or not? Because you're saying, oftentimes what we'll say is right upper quadrant pain, gastritis versus acute cholecystitis versus cholangitis, right? I just listed 3 possible things, and I might have listed it in order of what I really think is true, but a person that's reading that note will never know what I'm trying to say, right? We've also been taught to be purposefully vague.
Purposely vague.
Purposefully vague. So you know.
There's
so
space for them to code
exactly. So I can come back in the future and dodge lawyers, right? Like chest pain, plausibly not cardiac related, considering cardiology consult, right? Because I know this patient is crazy. He complains about chest pain every other day, and we've ruled it out in the past. But on the off chance one day he gets a heart attack, I was actually thinking about calling cardiology, but I never did it. I considered it. I wrote it, right? I wrote it. It's weasel words, right? Cardiology goes, I was never consulted, but I clearly wrote it, right?
Okay.
You guys kind of getting the gist of how hard this is?
Yeah, sure.
Yeah.
It's very interesting, I would say. Very challenging. Yeah. Very interesting.
Well, okay, so can I suggest something? I'm selfish, so as a surgeon, I'm very selfish. Let me just show you a nugget of something that you might actually make an impact in.
Yeah, we love solving nuggets of problems rather than solving the whole thing.
I mean, what you guys are interested in, I personally believe is a belief that it requires a paradigm shift, and it's going to be impossible in your lifetime. But let's say I write a report about what I do in an operating room, right? Can you boil down my operative report into key steps?
Like do a summary of that and
Like guide you as you're writing it?
Or vice versa, right? So there are these things called synoptics reports, which were in certain procedures are so well structured that you can essentially boil down into checklists, right? So for instance, I want to take out your gallbladder. There's certain steps that almost every surgeon does, and it can be boiled down to a checklist. Like, I entered the abdomen, I developed a critical view, I snipped the critical structures, I ensured blood was stopped or bleeding was stopped, I closed the abdomen, the patient did fine, right? Those are like 7 key elements, and everybody will have a different report type, because what I say into a dictaphone and what the next surgeon says into a dictaphone, probably the language is a little different, but we're all describing the same operation. Does it make sense? For the sake of research, there's a lot of interest in structuring these types of procedures so that when we go back and ask a question, did a surgeon do X, and did I change outcome? Or did medical procedures do this, and did I change outcome? We can go back and say, forget reading the paragraph. All the data is there. Does that make sense? So
Mhm.
I can show you a typical operative note for.
Yeah, it's almost like English is a language that nobody really speaks in this field, and everybody has to speak it.
It's a whole different language.
It is a whole different language. So how do you deal with it?
So I come from a completely non-medical background, right? So I started with I learned general NLP. So when I started with NLP on EHR data, I had a very tough time initially because there were so many abbreviations and things. But one of the things that we did is that for a lot of the out-of-the-box tools that we have, we usually train those on a lot of unstructured clinical data, just so that those models can now learn exactly how these sentences are now written, because not all notes are bad. They have this sort of a semi-structure feel in it. It's not structured. Like, say you have different sections, right? Not all sections are treated equal. There are some sections that are more important than others. So for your billing, maybe the actual problem list section, the assessment and plan section, and maybe the history of present illness. Maybe it's like 3 out of whatever number of sections are actually important. Like if you want, okay, I can say you could argue that, okay, maybe I'll miss 20%, but your most important 80% should be within those 3 sections. So you could start with just filtering out the sections that you need. Once you filter, because there's a lot of noise, there is a lot of noise, like what you mentioned about the review of systems, like negative for HDN. You don't know what that means. So I would advise, look at the clinical note, remove as much as you can, try to get the top 80%. Forget about the 20 because it's going to be a long tail. Go for the majority points. Go for the top 80. So throw out as much noise as you can. Look at just a few sections. Start with a higher precision model. You lose a bit of recall. For the beginning, that's fine, because your demos tomorrow, you need to have something out there that's working, that looks decent. For example, if you have something like HTN in your note written clearly, and if you don't have that showing up in your CPT code, that's bad. But if you have something like, no, he also had chest pain with something, which was deeply embedded somewhere, you may not be penalized as much as missing something that is glaringly out there that you should have absolutely picked up. So I would say, if given the short amount of time that you have, focus on the top 80%, forget about the tail 20%, you can fix that later. Just focus on a couple sections. I mean, that's how we usually do. We just try to get rid of the noise as much as possible. And then, once we have that, then we go from that to the coding. I mean, that's how I'm thinking about it. I mean, that's how we did
Okay.
with it. It took me some time to get used to the EHR stuff, but I think once we did, I think one of the initial things it took me was to understand which note sections were more important than the others.
Right.
How do I remove certain note sections? Like an assessment and plan section could be A/P, it could be assessment and plan, it could be impression and recommendation, it could be just impression : so there are like, so you could just do a simple grep. If you have access to these clinical notes, you can literally just do like a couple of Linux commands or Unix commands, and you will get like the top 10 most frequently used section headers. Just use that, write a simple rule, get those chunks of text out. Within that, there might be some semi-structures for those headers, maybe some sort of a colon at the end or some sort of all caps or something. Get those out. Once you have those, take that list. For that list, get the codes, get that out. You may already get a 65% accuracy with that. Once you're done with that, then move to the next. I would say just go with it like step by step. Start with the easiest thing, the lowest hanging fruit, then move from there. Because I don't think you can do all of it before tomorrow. Yeah?
Yeah. So I think you're going to talk about just the different, the checklist, right?
Yeah, you were talking about a checklist.
Yeah. Wondering if.
Oh, me.
Yeah.
Sorry. Yeah.
Did you finish going through that? I was wondering if you had any more thoughts about that idea.
I didn't realize this is all due tomorrow.
Yeah.
This is hard. But like, here's I'm just giving an example of an operative report. Have you dealt with operative reports ever?
Mm-hmm.
So were you imagining something that like based on you check some of the checklist and then like generate a report for you, or? That's
right. You capture key steps of an operation from a narrative. Let me see if there's a here we go. So this is a classic template, right?
This procedure is one that is very
This is very common.
Okay.
Right? And a surgeon can literally go to this website and just read. This is so and so. They're taking an operating of a patient with an MRI of this, and I'd like Dr. So and so to be copied on this, right? What procedure was done? Pre-operative and post-operative diagnosis. Everybody that was in the room. What I found, and then this is all kind of an attempt to structure the note. Then here's the free text, right? Patient's brought to the operating room. He was given antibiotics. Anesthesia was induced. A Foley catheter was not inserted. Arms were not tucked, right? He's highlighting in italics things that are potentially editable, like practice variations, right? Here's how he entered the abdomen, right? If you can capture something like this and make it into like a tree, right? Some kind of hierarchy, right? And check off against 1,000 operative notes. I think you might be onto something that's potentially useful for people that are interested in research. Right? I mean, here's my this is not related. This is complete tangent. Here's my wish. Right? You just have a camera watching me operate, and you can generate this note from just watching me operate. That would be awesome. That would save me 10 minutes.
Do you envision if we create something that helps you generate the note, but not as advanced as from the camera feed, but if you're able to write shortcuts, in your mind, do you have is it possible, hypothetically, to just define a whole bunch of shortcuts that allow you to generate this?
Yes, right? So, is it possible, because we all kind of use the same language as we talk to each other, is it possible to build a dictionary of those expandable acronyms I was talking about, right? In all scripts, it's called dot phrases. So I go dot, APP, right? And it will expand a note about appendicitis.
Why is that not good enough? Is that good enough?
That is good enough. As of 10 years ago, when I think the EHR people were, the government was kind of like putting constraints on things. They didn't want to use acronyms because they said they would influence how physicians documented their notes, right? It's cheating, right? So the concern is that if everybody copy and pasted notes, that all the notes will be same across all patients, when clearly that's not possible. Does it make sense? But I think those concerns have been relaxed, so that these kind of italicized areas could be modified as needed, right? But if you look at some of these notes that uses scheme, these will not be filled, right? The physician just forgets, or certain sections will be not edited, and they were actually not done. Guilty. So it's hard. It's hard. The notes are very noisy. They're filled with errors, and with the advent of EHRs, right? Now you have to parse. What does this mean, right? Triple underscore. Have you even heard of that? Like triple underscored hypertension. Does that mean like positive hypertension, negative hypertension? Just didn't ask. I don't know. Like what does that
mean? Is that a shorthand for something?
Well, sometimes like these EHRs will give you essentially a checklist. Like the worst offenders be VA. CPRS is a very antiquated EHR system, and in the past they tried to automate certain notes by making it like a checkbox, right? I review systems, and it will have like a bracket, hypertension, bracket, coronary disease, bracket, right? And you're supposed to go in and X out the things that weren't done, right? But what happened was people would forget to delete the things that were not relevant, right? And so these notes will be copy and pasted over and over, and so now you have notes that are just 10 generations of bad copy and pasting that are essentially unreadable. Right? Like past medical histories that no longer are relevant. You know, like front tooth dropped out at the age of 3.
Oh, sure.
Right? Like why do we care?
So there needs to be kind of a balance between efficiency and like in like communicating your intentions.
Right. You know, I like this in a magical unicorn world, but like, you know, I can do this. But maybe what you guys need to do is develop an app that teaches students how to like speak and code that are legible.
Hey, if we can get students to use it.
Right, like if we are trained not to do this, but something like this that can be perpetuated, that would be huge.
So what is this?
Well, this is the front
This is
end.
just we just thought, hey, can we get generate codes based on reading unstructured text?
Right.
So
I copy my paste note, and they give me the CPT.
That would be fantastic.
Hey, in a magical world, right? If it works. So what can you expand on what you're saying regarding teaching students the code?
No, right. Like it's like I want to create a functional computer program. Right. You pick a language, C, but you can't just say C is completely arbitrary, right? C is whatever I want it to be. C is structured, right? There is a book that tells you all the keywords in C,
And there's
and how
best practice how
Right.
to
and
code
there is a syntax, right? If you teach medical students not only just about human anatomy and physiology and whatnot, but a syntax for communicating to the outside world, and ensure that they use it, right? Put some kind of like framework around it, and you're the first to do it. That would be huge.
I mean, develop a structured language
A structured
basically.
language for medicine.
for writing those.
Yeah.
For writing, like after then you can use a compiler something with a very precise
Yes.
syntax, and then you can extract everything that you.
It's like
Yes.
it's like right now you're talking to computer English.
Well, but that's really what we're headed towards, right? That's what coders wish, is that we spoke in just pure CPT9 codes, right?
Right.
So would the UMLS resource be a good way to start?
I just heard about this. I've never heard about. I've never used this, but is it something similar to what I just said? Because I would love to look at this.
The UMLS?
Yeah.
Oh, you haven't looked at it?
No. Yeah, here.
Oh no, it's
See.
freely available.
So I'm gonna go home and start a new company.
Join our group.
No, I'm just gonna quit medicine.
So what you were talking about, speaking in code.
Oh, interesting.
I'm so glad that we have so many mentors that are.
Yeah,
Amazing.
that's what it means. Oh wow, this is like code for medicine.
I'm just gonna
You can save it.
save it.
Okay.
Yeah, so it's gonna be something like, I don't know, HDN. So you're gonna get all of the expansions. These are all your QEs, which are basically your medical codes. And then there are ways for you to then map these QEs into the CPT code. Or, so say you have a code.
They're just not very usable.
Yeah, see, you have CPT. So you could put HDN, you could put CPT.
It's like a dictionary.
Yeah, it's almost like a dictionary.
Okay.
But what if
So
you
this is
made
what-
that dictionary like seamless as you're typing?
Exactly. That would be great.
Boom.
So this would be a great resource for you to just use. And then you can download all of this. So
I
UMLS
think we hit something big.
Wow.
I'm excited.
So they
You want to
have-
invest?
You have the UMLS meta thesaurus, you have the vocabulary, and they are gigantic files, guys. But there is this file called the mrconso.rrf. It basically has all of these concepts like HDN or hypertension or diabetes mellitus, DM, DM2, whatever. and then it's going to have the corresponding codes for it. So you could use that potentially as a dictionary. And
To
then
look up these.
to what he mentioned, like whatever you're saying, like maybe there are certain words in certain sections, maybe just to reduce the noise, just look at certain sections, and then like what he said, as in when people are typing, you just try to map it to something in the dictionary, and then try to surface those CPT.
And then maybe like whatever that physician types most often, those can be the first few suggestions.
Exactly.
I mean, hell, if you can write a program that takes any random note, unstructured note, right? And in the end, they're all unstructured, right? And generate something that is codable. Forget the next step to make it into a code, right? Just replace all the acronyms with the appropriate expansion, right? HTN into hypertension, such that you're accurate 99% of the time. I mean, that'd be huge. That'd be huge, right? That's the next step to what you guys are doing.
Yeah.
And it would help a lot with like the interface with billers and coders, because most of the time they're asking us, what do you mean? You know, this patient has HTN, but his systolic blood pressure was 90. Right?
That seems like on the surface, it seems like an easy problem because you write a software to just replace. You know, just like Microsoft Word, that's find and replace, right? But is the difficulty like HTML might mean different things depending on the context?
Because our language is so unstructured and so like freewheeling, right? Like we just write whatever comes to our mind.
I mean, one of the simplest things is you can imagine Miss Lisa comes in today with a problem of hypertension. And sometimes the miss, which is MS, it could be multiple sclerosis, depending on the context, or it could literally just be miss in a completely non-medical sense. Like, it's very, very context dependent.
Interesting.
Yeah. So you have to get that balance.
But like, if this is the case, like, would it be like some input software, like while you typed HTN, if it auto suggests like hypertension or
it's
whatever
like Gmail.
Yeah, it's like Gmail, like, and like auto suggest, and like you tap, and then like choose.
But then you can open a dictionary while you're doing that.
Yeah, so like would that be something?
Auto completion.
Yeah, auto complete.
Yeah, just inline autocomplete.
In the medical terms, yeah.
But it has to be like the UI UX that the other guy was talking about, right? It has to be seamless.
Right.
It can't be interrupted every time, right? You can't ask me a question for every other word that I type,
Right.
right? Which is hard.
And I guess like it's gonna like be smarter, like as you type, for example, like if you're a cardiologist, then like most of the time HTN means hypertension, then like we learn it, and then like you can manually change it afterwards if you don't, if you think it's wrong, but like we'll give you the most probable one.
Yeah.
I mean, if you have, you know, it would be useful to me if you can have a personal scribe that's learning in the background, because I do certain things often, right? I write certain things often, and I don't have the time to make these acronyms that expand. So as I'm trying to type, like not just autocomplete the next word, autocomplete my paragraph, right? Just like that, right? I'm typing, the patient is placed on the table and given before you even finish the word antibiotics, right? The next 5 sentences show up. This is the same thing, right? After I give antibiotics, I intubate the patient, I put sequential protein, right? All these things are pretty much rote, but I'm saying it to a dictaphone or typing it down. It's a waste of time. Or I see a patient, right? Like I've already started to write down specific qualifiers for the patient: right upper quadrant pain, nausea and vomiting, fevers, right? And as the